Mm-hmm.
So I think we need a few more minutes while people join.
Yeah, we can see the numbers are ticking up quite
How
nicely.
many were we expecting approximately?
We had over 400 register. But I know some people will want to listen to it later and not necessarily join tonight. But,
That's right.
So we're over 100 already. Minutes. So yeah, it's obviously popular.
Oh, thanks, Jen.
In case I forget before the end, all the work that IMAC does on this is really appreciated. And the timing of this is perfect. So thank you.
Oh, thanks, Joe. Well, it's just great to have the collaboration with us all.
Yeah.
Yeah, we could have got onto it a bit earlier, but I actually think in a way this is an advantage because we've learned so much. So now that, the learnings that we've had are really useful to help practices now that we wouldn't have known a month or two back.
No.
I like Rachel's background. This is where I want to be.
Yeah, I bet there's a lot of people joining that would like to be somewhere like the background like that.
To anybody who's from Auckland, sorry.
I was just saying, Nikki, I can actually see the Remarkables out my window, but
oh, Joe,
it's gone dark.
Is that where you were skiing, Joe?
Cardrona today.
Cardrona.
Nice.
Remarkables yesterday and the day before.
Oh.
Now you have made everyone jealous.
We did have an aborted landing on Sunday. So
really? What was the weather was bad?
Yeah. So there was some adversity.
I'm so sorry. Just feel for everybody from Auckland, yeah. And we can say that Joe doesn't come from Auckland and he didn't get an excuse to run away to Wanaka.
Hope it goes well, Kate.
We're still building up numbers, or we're
it's settling down about around the 165.
I think we're just super keen to get started. We'll wait another minute. We're so enthusiastic.
It's only 1 minute past. So.
The problem is I'm in Wellington and the weather outside is really noisy. I don't think you guys can hear it, but the wind is howling. Good old Wellington. Well, I think if we're happy, we could probably get started, no mai haere mai piki mai, ko Nikki Turner toku ingoa, ko Medical Director of IMAC, aho. I'm also a GP in Wellington, and welcome, 3 times welcome to everybody tonight, and for those of us who are able to watch this later. Thanks everybody for listening to this. And the reason that IMAC is choosing to run with this webinar and possibly a few more is that, as we all know as GPs, that the early arrival of the Pfizer COVID vaccine earlier this year, we weren't actually initially engaged in delivery, particularly with the difficult early cold chain issues. And then when the cold chain got easier, we have all been in a different position and able to start moving into delivering COVID vaccines. And it's fantastic that many of us have been able to move into delivering vaccines. But we've also found there's been a lot of learnings along the way. And some people have found it really tricky and complicated. And what we've learned over the last month or two, we felt this was a really good opportunity to be able to share with our colleagues the learnings from practices that have already got up and way with COVID vaccines, both the things that have worked well and the barriers that people have found it hard. So we thought, with lots of support from primary care and also from pharmacy, that we hope to be able to share our knowledge and experience and resources to help those of our practices that are still planning on getting on board with COVID vaccines. So that's the intention of our webinar tonight. And we really look forward to questions and comments from people, and hopefully our services and support can help as we go along. And the people we've got with us tonight to help, firstly, I'd like to introduce Kate Marshall, who is our COVID immunisation education facilitator in the South Island. And Kate is actually going to lead us through the presentation and the questions. And Kate is ably supported tonight by Jane Morfitt, our IMAC COVID education manager for the country. So welcome to Jane. And Rachel Hall, who is from the Well South PHO. Rachel's the lead COVID immunisation coordinator in the PHO. And we're also really pleased and welcome to have Dr. Joe Bourne, who's also a general practitioner, and he's the vaccine immunisation program clinical lead for the Ministry of Health. And Joe is actually giving up an hour of his holiday to join us tonight. So thank you so much to Joe. That is really over and above the call of duty. So just shows you the commitment of general practice. So kia ora to Joe, it's fantastic. So with no more further ado, I'm going to stop talking now. We're all just going to sit in the background and hand you over to Kate to lead us through the presentation. Kia ora, Kate, thank you.
Nikki, just before we move on to that, just to let people know that the chat button's been disabled, and if they want to ask questions, they can type them into the Q&A button, and we'll answer the questions at the end.
Lovely, thanks for that, Nikki and Jane. All righty, hopefully everybody can see that on their screens. Now, welcome very much to everybody for coming tonight and taking the time to attend this webinar. So as Nikki explained earlier, the aim of this session is to help provide you with some real practical information and advice around setting up and starting your vaccine clinics for this COVID vaccine. So please do, if you do come up with any questions during this presentation, feel free to pop them in that little Q&A chat box as Jane mentioned, and we'll address them at the end of the session. Now, I'd just like to start with a karakia for everybody. Tu taua mai I runga, tu taua mai I raro, tu taua mai I roto, tu taua mai I waho. Kia tau ai te mauritu, te mauri ora ki te katoa. Homie, hui, tai kie. Now, you can see from the contents that we've got quite a lot to touch on tonight. I'd like to go through some of the tools of the trade that are available to you, some resources and guidelines to help you get set up. Then we'll talk about some of the early planning and delivery model considerations. We'll touch on some things that will help make sure you've got the right people, the right time and considerations in the right space to run a COVID vaccine clinic. I'll talk to you about some of the workforce training options that you have available to you. And then we'll touch on the actual nitty-gritty paperwork. How do I get commissioned? How do I set it up? I'll touch briefly on some contracting and funding information for you. And then we'll explore what the terms dry run, wet run, and your go live date mean. Finally, we'll discuss a little bit about how you're going to be managing your business as usual while trying to run this new COVID vaccination program in your practice as well. So plenty to talk through. Now, this infographic has been taken from the Primary Care Onboarding Guide, and it outlines all the steps that you need to take before your practice starts delivering the COVID vaccinations. Now, at first glance, it can look quite overwhelming, but with some planning and talking to your DHB and a lot of deep breathing, you can do it. Now, you can see on the left-hand side that there are some priority actions to start with, and these include formal agreement with your DHB and training your staff up. And then the process moves on to your site setup activities, your clinical considerations, so your quality, your safety, and your equity planning, then onto your workforce onboarding, and finally, site rollout and your operations. Now, in terms of thinking of a time frame to work to, please allow at least 3 to 4 weeks from start to finish to get your staff trained up and for the ministry to set up your practice in the system as a live site. So I'm going to talk through these aspects tonight with a view towards the practical advice and tips. And these are mainly based on experiences that I've had and also through the experience of WellSouth, who have rolled out the GP COVID clinics in Southern District. Okay. Now, sorry, these here are all of the optional tools and reference guides that you can use to help your team. Now, some of these documents you'll already be really familiar with, such as the Immunization Handbook and the Cold Chain National Standards. Now, IMAC is going to send a quick link document to everybody who is registered for this webinar. So you'll be able to access any of the resources that are referenced in this presentation tonight. Now, the main primary care documents that I really want to highlight that will be helpful for you are the Primary Care Onboarding Guide. Now, this is a real how-to manual. It breaks down each step of the process. It has really good practical advice and some numbers and emails that you can reach out to if you need any assistance or are confused about anything. There's also the Primary Care Planning Considerations document, which is AKA the blueprint document you may have heard of. So this is also very helpful, and it's got some really good suggestions at the back of it around how to connect with different communities. There's also the COVID-19 vaccination operating guidelines. Now, this is really comprehensive, this document, and lots of fine details. It updates at least once a fortnight, so it's really a good idea to have it just saved on your computer as a reference rather than printing out a ginormous book. There's the Athena app, which the ministry used to update providers on all things COVID. And IMAC have got a suite of resources on our COVID-specific website that will provide you with education and training information and support. And as well as all this, there's the ministry newsletter, which I recommend that all providers sign up to for the latest information. Now, we're moving on to talking about some of the early planning and delivery models that you want to consider. Now, this early planning will help you to deliver a safe and successful COVID vaccination clinic that will suit your staff and your practice, and it will also help you get your community vaccinated. So key things to start off include making sure that you're aware of the local onboarding process. Now, DHB processes differ up and down the nation in terms of the support available to new sites setting up. Some may be really well resourced and very hands-on with providing visits to you and support for your wet run or your first clinic, whereas some are more hands-off and might let you navigate the system a little more independently. So please find out as soon as possible what their process is, and this will help you know where you stand from the get-go. The next important thing to start thinking about are your equity considerations. So how are you going to design and promote your clinic so that you can boost access and uptake of the vaccine for all members of your community? So consider the concept of extending mana manaki. So this means extending respect and hospitality. Now this comes naturally in primary health, but it's an important concept to use when you're trying to think of how to reach your vulnerable populations. And just try to really focus on an atmosphere of celebration at your practice. You know, if you give the vaccine in a way that's celebrating that person and making them feel proud, they're going to go out and tell their mates and whānau to come and get it too. Get your staff training as soon as possible. The sooner they start with their CIR training and any vaccination training, the better, and you'll be more organised. And a little tip that has been a bit of a stumbling block for some practices is that staff who are going to be using the live CIR site, they all need to have their own individual business email addresses set up. And that is a security mechanism for getting into that live site. Alrighty, so primary care know how important a well-functioning and cohesive team is for success, right? But some of the key tips for preparing your team to run a COVID clinic is to involve your practice RNs straight off the bat, involve them in your planning and figuring out how you're going to run the clinic. So based on experiences with the GP rollout down in Southern, the most successful and smoothly run clinics seem to be those where the practice RNs have been involved right from the beginning. And this is because they're usually the person in the practice that is the key vaccinator, and they do all the cold chain. So they need to be across all the aspects of this vaccine and its particular cold chain requirements. It's really important to identify the roles in your clinic. Who's going to be doing what? In a GP setting, you need a clinic lead. You need at least 2 COVID vaccinators to do the vaccine preparation. So this is the drawing up and checking each other's work as you go. You need an admin person to be the arrivals person and the greeter on CIR, and a CPR trained person in the observer role. So in primary care, this observer can be the receptionist, absolutely, just like you do with any other post-vaccine wait. Now, it's really important to try and get all your vaccinators, so GPs and RNs in the practice, familiar with how to draw up the vaccine and how to use CIR really well. And that means that you'll have depth in your staff just in case somebody has sick leave or takes a holiday. It's good to know how to run the ship. Righty-ho, so the next thing to consider is the timing for your clinic. Now, this is important both in regards to the preparation of the vaccine and also the practicalities of when to hold your clinic. So this vaccine is a multi-dose vial, and it does take time to dilute it and draw it up. So you need to allow about 20 minutes for it to warm up when it's out of the cold chain, and then about 5 to 10 minutes per vial to draw up those 6 doses, and we're aiming for 6. You must allow sufficient time for the checks to happen to make sure everything's done safely, because errors can be made if things have been rushed or if staff are distracted. Now, depending on the volume of the doses that you're delivering, it's wise to start your drawing up process around an hour before your clinic actually starts. All right, so when you're thinking about what time you should run your clinic, I advise you to go and talk to other GP practices that are of a similar size to you that you know are already running it. Get a feel for how they're doing it. Maybe consider blocking out a couple of hours 2 times or 3 times a week to actually dedicate to running this clinic, or perhaps an after hours clinic would be more feasible for your staff and for your clinic. Now, the physical space of your practice and the waiting room in particular can be quite a limiting factor for COVID clinics. So with this vaccine, you've got a required 15-minute observation period for people, and this can be up to 30 minutes if they're a high-risk person. So make sure you've got enough space and enough chairs to recover these people, as well as dealing with your business as usual appointments. So ideally, people after they've had this vaccine in observation should be kept separate from other business as usual patients and people arriving for the vaccine. Now, this may not seem practical or suit the layout of your practice, however, so just think about creative ways you can clearly delineate between the people that are pre-vaccine and post-vaccine and those that are coming in for their routine appointments. Maybe create some VIP chairs for them to sit in, perhaps. And some creative practices have used their car parks for drive-through clinics. So if this is something you want to explore, please do talk to your DHB and have a look at the Ministry of Health drive-through planning considerations document, which is on their website. Now, in terms of site safety, your practice will be well experienced with screening patients for COVID symptoms now, and you know how to use the right PPE. I just want you to consider, though, how you're going to factor in the increased flow of people in and out of your practice, and especially when we're under, varying alert levels up and down the country. Consider perhaps using a different entrance for your COVID clinic attendees. Now, if you're doing vaccinations and swabbing at the same time, try to keep the staff doing one of these roles each day. Or if you have to change what they're doing within the same shift, make sure they go from a clean job, which is vaccinating, to a dirty job, which is your swabbing, and that will help reduce the risk of infection. Considerations for your observation area. So it needs to be directly in sight of the observing receptionist. They use the CIR computer in real time to kind of count down that 15 minutes for their observation, and they use it to release the patients. So they have to be monitoring the patients for early warning signs of faint or anaphylaxis, and they need to be able to easily call for help for the vaccinators and the GPs. Now, when clinics are busy, there's no real way that it's safe for the observer to do any business as usual work. So don't expect your receptionist to be able to take phone calls for other kind of work. If you've got the staffing and if it's possible, consider getting another person to do the arriving part into the CIR, because often this comes with questions around booking and having to alter that for people. So it can get really, really busy if it's just the one person doing that job. But at the end of the day, it's not really a lot different from running a dedicated flu clinic, though there is an overlay of the CIR for people to deal with too. And you do need a little recovery area, which should be easy enough for people to figure out where to have that in your practice. And that's just in case of any adverse events, just like normal. Right, so let's say you've got a rough plan in mind how your clinic will function. It's time to look at the paperwork. And this is often the bit where people roll their eyes. Oh, but it's not too onerous. Now, the first thing is the DHB will give you a CIR user form and an NBS, which stands for National Booking System user form. So this is to get all of your staff you anticipate will be using those systems, set up. So until staff have completed their CIR and Book My Vaccine training, you won't be able to get access to those sites, but they will get access to the CIR classroom. The next little bit of paper is the site checklist. Now, this is found in Appendix A in the operating guidelines. The DHB uses this to kind of sign you off to make sure that you've covered all the bases for safety and you've considered everything, and this will satisfy them. It may involve discussions and a site visit from an immunization coordinator or a representative from the DHB, and really use them as a resource with any questions you may have. The DHB should provide you with a resource ordering form. So this is like your initial order, what you want. You'll be getting information pamphlets, those little vaccination cards. You can order your banner, your flag for out the front doorstep, the consent forms, and much, much more. So it can take about 2 weeks for all of this collateral to arrive. And your ongoing stock management, so things like your needles and your syringes and your swabs, they all come with your vaccine delivery, but you can order extras using the CIR inventory portal. And the final bit of paperwork is the site facility setup form. Now, this is what your DHB will send to the ministry to formally set you up in the system. And when the DHB receives this, it can take 10 days for them to kind of process it and get everything sorted. And then they'll be able to deliver some vaccines to you. Right, so moving on to the training requirements for the workforce. IMAC is the contracted education and training provider for COVID-19 vaccination rollout. This table kind of breaks down the available courses to deliver this vaccine program at your practice. And there's also some optional training, which is based around consent for persons with disabilities, if you're interested. You can see the vaccinators all need to do the COVID education course, and this qualifies them to be involved with vaccinating the Pfizer vaccine. It also includes CIR and the Book My Vaccine training as part of that package. For your admin staff, there's the admin, CIR and Book My Vaccine training. There's also an optional immunization support worker training module that non-clinical staff can do, and I really encourage them to do this if they've got the time, because it teaches them how to have really valuable conversations with their community and their whānau around immunisation. It kind of spreads the good word, and it also provides some information around the observation role. There's also a managing inventory in the CIR training module that practice managers or whoever looks after the stock at your practice might find useful. And all of this training is available on the IMAC Learning Management System website, and you just need to register for that, and you can search and access these free courses. Right, so the main groan zone for the onboarding is getting staff onto the CIR. So look, this extra IT component can be quite daunting for some staff, but it is intuitive. It's fairly hard to break, and I have tried to break it. And it's a lot easier to use than your patient management system. So just remind staff that it's okay to, feel a bit wobbly, but they'll be fine after a few goes. Now, the process of onboarding can be a little bit of a rigmarole. However, we'll get there. So first of all, the CIR user form is sent to the DHB. DHB sends this to the ministry, who then flick out links to all of the staff for the classroom. Staff complete CIR training on their IMAC website. And then once this training has been completed, the DHB requests that the Ministry of Health get all of the links for their live CIR access. The live CIR access comes to the staff as a password reset email. But the tricky thing is this link expires after 24 hours. So you have to make sure your staff are keeping an eye out for it. If they miss it, it's not the end of the world. There's a really helpful CIR helpline number which people can call, and there's lovely people at the end of that which will support some of those perhaps less IT savvy people through the process. Finally, staff need to download an app called the Salesforce App Authenticator, and they can find this through their Google Play or however they usually search for apps, and they need that on their phone so that they can set up their access to the CIR site that first time, and they need to use this every time they log in. So the support number is listed on screen. There's also a really helpful CIR onboarding document with finer detail for those that really like to know the nitty-gritty. And every day the ministry hold a Zoom meeting in the mornings, which is a Q&A session for staff that are unsure or come up with any problems related to CIR or Book My Vaccine. A good tip is also to log into your CIR account every couple of weeks, because this helps keep your account live and active. All right, so we're going to move on to talking about dry run, wet run, and your go live day. Now, these terms might be new to people. So the dry run, this basically means a practice run where there's no vaccine or CIR access required or volunteers. It's a walk and talk through the roles with your staff, an opportunity to talk about the flow, think about your infection prevention control. How's it going to go? Use the opportunity to talk through what staff would do in an adverse event situation. A reminder, where's the adrenaline kept? Now, a wet run, this is when you actually use real vaccine and real patients, lovely volunteers that you have gathered to help your staff get ready in a more informal, supported way. So it's really good to use at least a couple of vials. So that's around about 12 doses to get all of your vaccinating staff, give them the opportunity to have a go with CIR and to do the drawing up as well. Now, it's best to hold your wet run after hours if you can, and within the week prior to going live. And that's so you remember things when you're actually in your real clinic and your staff are also concentrating. Make sure everyone's got their CIR login sorted too. That'll save you some headaches. And then a wet run can take around 2 hours. Now, it's really good to check with your DHB if they're going to offer you anybody to help support you with that. And I really encourage you to ask for assistance, at least a clinical person and an admin person if they can spare one to help the administrator with their CIR. Now, the go live day is your first real clinic. So again, useful to have a support person. Try and start earlier than you expect, because it does take time to draw this vaccine up when you're starting. And there's also some cold chain considerations you need to be really careful with. Now, make sure you've got all your handy helpline available. So you've got your CIR helpline, and you've also got your IMAC 0800 Immune phone number, which is for any clinical questions that might crop up. Okay. Now we'll just touch briefly on contracts and funding. Now, the contract does get set up with the DHB quite early on, before the ministry are involved. So the DHB base their allocation of vaccines to be delivered based on your enrolled patient population, but it might be adjusted depending on where they're at with their overall population plan. It's good to check if you can negotiate the numbers that you are willing to do, if you want to do less or more than they are initially offer. So you can see on the screen there the table which describes the pricing for the doses in hours and out of hours. And for those that are interested, the out of hours is defined as 8 o'clock at night till 8 a.m. in the morning, Monday to Thursday, or after 5 o'clock on Fridays to 8 a.m. Mondays or public holidays. Now let's talk about managing business as usual. Okay, so this kind of introduces yet another layer to your already busy workload at your practice. And this may seem quite overwhelming. However, once you've got your clinic set up and you've got your training all done, providing this vaccine to your community is actually really rewarding. And offering this service is fantastic because there are people out there who are nervous, who don't want to go to a mass vaccine clinic. They want to be vaccinated by their trusted health professional at their local GPs. So look, it is important to acknowledge that there are challenges that lie in delivering this vaccine and also trying to keep up with all of your other essential vaccines on the schedule. So just think about ways that might help you deliver the vaccine in a different kind of model. Maybe weave the appointments through the day, maybe have those separate dedicated clinics or an after hours clinic, or if you're in the position to adjust your staffing numbers, get some more vaccinators or another admin person to support, and reach out to your colleagues. How have they done it? What did they learn? Now, to put all this information into context, and I know there's been a lot of information, so thank you for persevering. I want to share with you some of the experiences WellSouth have had. Now, WellSouth is the sole primary health organisation down in Southern District. They've got a total of 81 general practices district-wide, 63 of whom are now onboarded and delivering this vaccine. So WellSouth shared with me that the GP rollout in Southern started really early in the year, so around the March, April mark. And this was when after they recognised that the Queenstown Lakes area posed the greatest risk in terms of vulnerability. It's a tourist hotspot, there's no large base hospital there, and there's reduced kind of access to the vaccines as there's no mass vaccine clinic in that area or was being planned in that area. So they decided to just go ahead and set up any local GPs that were willing to provide the vaccine. So look, they did find it very, very challenging to do this early on. They felt that the focus and the guidelines were just on the mass vaccine centres early on in the pace and just focused on getting it to those early scheduled groups. And it wasn't terribly primary care focused. However, this meant that WellSouth has been really involved in pushing for primary care to be more involved and to deliver this vaccine in practices. And they provided plenty of feedback to the DHB and to the Ministry of Health around ways to adapt how it's delivered in a practical sense in primary care. So the way that they did it, first of all, they started to have conversations with the GPs that put their hand up, and this was between the practice and the practice relationship managers. And then this progressed to a face-to-face hui with them to talk about the contracting, to go over the forms and to make sure that any questions the practice had were listened to, and some advice was provided about the way to make it roll. Now, WellSouth required that each GP practice did a supported wet run to ensure that it was smooth and successful when they went live. And they provided a person to support the first clinic. Now, this was all really resource intensive and took a lot of time and effort on WellSouth's behalf to organise. However, they reached out to the Southern DHB and to IMAC, and we all collaborated and worked together to provide enough staff, like immunisation coordinators and admin support, to help cover all of these 63 clinics. So it was a fantastic effort. Now, on your clinic days, you may not have such a big support network. However, there are those call lines. Now, this poster is the Where to Get Help poster, and it's on the CIR live site, and it's also, all these resources are also sprinkled throughout the operation guidelines and other various documents too. So key resources, you've got your ministry logistics team for any vaccine or consumable supply issues. You've got your CIR people to help with any technical CIR issues or password log-on drama. And you've got your 0800 Immune IMAC clinical helpline there. In terms of the resources IMAC can provide to you and your team, we do have a dedicated COVID website where we keep lots of information. There's webinars that have been recorded from previous sessions. There's lots of documents that are solely dedicated to COVID vaccines, such as the instructions for drawing up and the screening guidelines there. And I'd just like to plug the latest resource that we've created, which is the Immunization Clinical Toolkit. Now, this is it's anticipated to be a monthly update, and it's a really quick kind of booklet that keeps all of the useful links and information around cold chain, vaccine prep, administration, what to do if there's an adverse event. Everything COVID vaccine is in that spot. And again, sign up for those newsletters. Okay, so in conclusion, I'd just like you to share these, have a look at these wise words from our WellSouth COVID Immunisation Coordinator, Rachel Hall, who's on the panel tonight. So general practices know how to deliver vaccines. Just think of this as one more vaccine on the schedule, though with a slightly more fragile vaccine and a whole of community delivery approach. So true. Now, this graph that I'm also showing is shared with me by the Southern DHB. Now, it's demonstrating how on a single day in August, when we were in level 4 down in Southern, close to 9,500 vaccinations were given district-wide. Now, most importantly, each different colour represents a different provider, and it just shows no matter how small your contribution, no matter how minuscule you feel it may be, it all adds up to getting the job done of vaccinating the country. Now, primary care are the experts on your communities. You know how to deliver vaccinations, so please be encouraged to provide this vaccine. Without you, it's going to take a very long time for us all to get back to a new kind of normal. So, yeah. And I'd like to just say thank you for your attention. And before we close with a karakia, I'll hand back to our panel so that we can answer any of the questions that you may have. Thank you.
Well, thank you, Kate. We've had a few interesting questions coming through here, which I'm sure as a panel between us will hopefully find some answers for. So if we start with, working my way up to the beginning of the questions. Regarding the paperwork, regarding the paperwork we need to complete, do we also have to complete our own site plan policy as per ProCare's standard operating procedures? Kate, you're on.
So I think that this would be a specific kind of DHB request. It's good for practices to have you've got your cold chain, your vaccination SOPs, and you can adapt these to incorporate the updated, the additional cold chain information around this Pfizer vaccine into that. That would be really helpful. Yeah.
I can perhaps jump in, Kate.
Mm-hmm.
So some DHBs are working with their PHOs and using the PHOs really to support them in that commissioning part of the process. And so those PHOs are developing some of their own tools to sort of assist general practices to be set up to succeed. So really the detail of those questions, you'd have to go through your own PHO if they're stepping in like ProCare are. But it probably is worth pointing out that some of the documentation that was produced at the beginning didn't really acknowledge the accreditation process that general practices go through with the Royal College of General Practitioners, and in particular foundation standards. So now all of the DHBs have, the GP College presented a document to the DHBs and said, look, this is what foundation standards involve, and this is where we believe they meet the provisions that are set out in the service specifications for COVID vaccination. And the DHBs all took that on board. So it's removed an awful lot of the steps that was previously involved in coming on board, such as some of the clinical governance arrangements, etc. So it's down to about 15% of those service standards that now need to be met. But it's difficult to comment on exactly what some of the PHOs are doing to support their practices to get on board.
Were there any other general comments you wanted to make, Joe, before we carry on with the questions?
There was just one thing to draw people's attention to that Kate didn't cover off, but thanks, Kate, for that presentation, because it really was excellent. When you're coming on board with CIR, there is an option for general practices where you have your own booking system, and you have a patient management system where you can record any clinical events, etc., where you don't have to use all the functionality of the COVID immunization register, the CIR. So when the COVID immunization register was designed, it was designed for these sort of new bespoke vaccination clinics that were set up. So it has a part of it that covers the arrival when you register people, a part that covers the actual immunization bit, the bit that really we're used to in general practice when we're completing a form that covers off everything within an immunization, batch number, the arm you've injected it into, etc. And then it has an observation period as well. Now, if your practice doesn't wish to use all three parts of that, you can do something which is just complete activities, where the vaccinator themselves can just do that middle section. So you don't need to use the registration part, and you don't need to use the observation part of CIR. And the team who support the training for CIR have got a special module which will talk a practice just through doing that.
That's helpful. And then I noticed there's another question here about Book My Vaccine training for people that have already completed their training before Book My Vaccine was up and running. Is there any way of, do we know whether there's any way of doing just that component, or would it be a case of logging back in to the CIR training and just scrolling through the bit you don't need and concentrating on the Book My Vaccine? Which I suspect is the answer. I'm just checking with my colleagues whether anybody else knows. I have to hold my hand up. I haven't needed to do the Book My Vaccine training.
There is a Book My Vaccine kind of onboarding journey document as well, which will come out in the quick links to everybody who's registered. And that document, when you open it up, it does show a few links to help with the training. So there's like the daily ministry training that they do at 9:30 in the mornings. That also does cover the basics of the Book My Vaccine. So it's quite simple. And there's a specific training for people that have been asked to get concierge access to the back end of the Book My Vaccine training as well. And that's something that you can request, that you're the nominated person at your practice to have that access and training from your PHO.
Thank you. There's a question here. Any useful tips from experience doing all of this through a drive-through basis, on a drive-through basis? Rachel, have you had experience of drive-throughs using?
Yeah, we have had a few drive-through, but there's a really good document that has been produced for drive-throughs. And I mean, I think every drive-through is going to be different, isn't it? So we've done some that were just a couple of hundred people, and we've done some that were over 1,000. I would look at the document and go through that. It does take a lot of organisation. You've got to have traffic control. You've got to have, you know, space, car parking space. It is quite a big deal. So I think you need a lot of support from various places, like, you know, police, bringing them into it for traffic control. You're going to have a big area to do it, where you're going to do it. We've done one here in Wanaka where they used an old Mitre 10 building. So we used the timber yard drive-through so that we had shelter for the people, and then there was heaps of car parks. You've got to look at a space to draw up. You've got to look at spaces to deliver the vaccine. If someone has an adverse event, what are you going to do with them? So it is a lot of organisation, but I would just refer to the document that's been written. It has it all in there to guide.
Thank you. I'm just looking, trying to get some logical order, but we're getting questions coming in fast and furious at the moment. What's the minimum number of staff you need to run a clinic? And also, what would the delivery rate be? We've got 2 nurses and 1 admin and 3 doctors to sort of set the scene, the practicalities of that sort of combination.
Oh, I can answer that one. So every practice is different with their staffing numbers. Generally what we say is, if you've got 1 nurse vaccinating, then you would normally vaccinate someone, or you'd have a 5-minute gap for each vaccination. And then, of course, they wait for a quarter of an hour after they have their vaccine. So for every quarter of an hour, you'll have 3 people that have been vaccinated, and you need space in your waiting room for those 3 people, and maybe 1 person who's waiting to be vaccinated. So we kind of look at 1 nurse vaccinating, you need at least 4 or 5 chairs in the waiting room. If you're vaccinating 1 every 5 minutes. If you've got 1 nurse vaccinating, most practices would have 1 admin on the CIR, where they are greeting the patient through, and then also observing them after the vaccine. But if you're having more than 1 nurse vaccinate, you really need probably 2 admin, 1 to bring the patient in, and then 1 to observe. That's what we've been kind of encouraging practices to do, and that's what they seem to manage with their staffing.
Thank you. And then there was also a question around, what's the minimum quantity of vaccine that can be delivered?
I can cover that off. Sorry about before, my Wi-Fi just dropped out.
Oh, right.
So 6 is the smallest number of vials that you can get in a box.
And each one's 6 doses, isn't it?
Sorry, 5
Oh,
vials. 5
yeah.
vials is the smallest.
And
So
yeah.
that's the equivalent of, depending on the number that you get out, people are tending to draw between 6 and 7 doses from a single vial, so between 30 and 35.
Yeah, and it usually has a shelf life of at least 2 weeks, hopefully up to 4, doesn't it? It's 31 days from when it's defrosted. So normally, depending on the way it's distributed, you'd usually expect to have at least 3 weeks to use that.
Somebody had asked them how it gets delivered. So, and sorry, I've been off this week, but it has been coming via DHBs for a while, but a lot of the deliveries are now, and I know certainly down in Southern, a lot of the deliveries go directly to practices now.
And then the question here, do we have to go through all of this just to vaccinate our own patients?
I should probably speak to that. I guess there's been lots of feedback, and I appreciate that when you're a practice that has been vaccinating children as well as adults for decades, and then you're confronted with this new process that is far more complex, that can be hugely frustrating. So I want to acknowledge that. And I think the focus of the programme, certainly at the beginning, was very much on these specific priority groups. And so it was a very centrally held vaccination. And so it's taken us a little while to come out to general practices and community pharmacies. But there is an amount of scrutiny on this programme that is far greater than most of the vaccinations that we normally do. And there has been in the past some pressure on vaccine supply as well. So whilst it can feel like this is just the stuff that we do all the time in general practice, there have been some really particular circumstances that have made this a little bit more challenging, hence the extra hoops that we're asking people to jump through before becoming a vaccination site. That being said, and I think Kate touched upon this during her presentation, we have seen the service specifications changing as we've gone through, particularly as the cold chain requirements changed, and making it far easier for general practices and other primary care providers to come on board. And we're seeing over 100 new primary care providers coming on board most weeks now. So there's a real momentum. So I can appreciate that it may look like a lot of administration to go through, but we are streamlining it as much as we're able. And I think there have been a couple of safety events that have happened in some practices, and I know that those have been publicised quite widely. So I think having a real rigour around setting this up to be as safe as possible does have some advantages.
I think what worked well in our area in Wales South was that we had an immunisation coordinator go to the practice and go through the paperwork with them, and that seemed to help quite a lot. We found that practices were really quite anxious about this program, looking at all the stuff they have to do to get on board and looking at the documents that are 70, 80 pages long. And I can sense it through some of these questions that it is a lot of work before you start vaccinating. But we found that whether it be a DHB immunisation coordinator, IMAC, education facilitator, or one of the Wales South people, and also our Wales South practice relationship managers, working alongside with the practice to fill in the paperwork, to go over what they needed to do, really helped them. And it certainly allayed a lot of anxiety. And once the practices are on board and have done everything, done their CIR, logins, it runs very, very smoothly. Practices are used to vaccinating. Yes, it is a bit more fragile, this vaccine, but once you're up and running, practices are just running away with it. And the patients actually have really, really, really positive feedback. Patients come in and they kind of expected a big deal, if you like, but actually they just see it as just getting the vaccine. They don't see the big deal behind all the setting up that goes behind with the practices setting up to do the vaccine.
Thank you. So there's a question here about how have practices cope with booking appointments 8 weeks in advance through the online booking system, especially smaller practices, or have they preferred to use their own systems?
I'm happy to jump to it, but others have practical experience as well. what we're seeing is, this is putting a bit of a number from the top of my head, but I think about a third of practices are finding themselves on Book My Vaccine. And I know areas like Southern have really encouraged their practices to be on Book My Vaccine, but across the rest of the country, it's far fewer. I think it's just a case of whatever works for you. If you're a practice that really just wants to focus on their enrolled population, then using your own booking system, and particularly if you've got a patient portal as well, is absolutely fine. And but if you're a practice that really sees this as an opportunity to reach out to the whole of your community, then having a presence on Book My Vaccine obviously gives a lot more visibility of your vaccine clinic to other people that aren't enrolled with you. And so you could find yourself with lots more people coming through. I guess as we make our way through the population and we get fewer and fewer people who haven't yet been vaccinated, those opportunities to have large numbers coming through and running it as like a separate commercial enterprise for your practice will become fewer, and there's probably going to be a lot more concentration on your enrolled population, in which case your own booking system might be perfectly adequate. When we were looking at times where there was greater demand than we had vaccine supply, having practices visible within Book My Vaccine was incredibly helpful, because it let us see exactly where the demand was and making sure we had all the vaccine in the right places in the country. But as we move into October and we're receiving 1 million doses in a week, then that need to keep such a careful eye on matching supply and demand reduces. And so again, having practices using their own systems is fine.
That's sort of then the other question here follows on really. There's a practice here asking that they're thinking of setting up and running sort of full tilt to start with for the first 6 weeks, vaccinating all of their vaccinating new patients. The following 6 weeks will be given second doses to these patients, but don't feel we'd have capacity to vaccinate new patients for the second 6 weeks. So we're worried about being locked into a 12-week cycle. Any ideas?
Yeah, I guess I think it's just a case of people seeing what capacity they've got. A lot of practices also find, and again, it'd be interesting, Rachel and Kate, to see what your experience has been, but the first couple of weeks are sometimes a little bit slower as well, and then they build up to the numbers of vaccines that they end up doing. I guess the details of your they call it, I learn all sorts of things working in the Ministry of Health now, production planning. When you're planning the number of vaccines that you're going to do, that's just something you have to work out for yourselves within your practices, and you'll be well used to doing that through the way you calculate the number of appointments that you have for each day. So try not to overthink it too much and just use all the sort of usual processes that you have. It's just on a slightly bigger scale.
And I think it's also useful to be aware that not everybody turns up. So you might have it fully booked for the first week, but actually 6 weeks later, when they're coming back for second vaccines, there will be spaces because not everybody will have come to those first appointments anyway.
Using the Book My Vaccine site, though, will help that. So if people are booking their vaccine through NIBS, then they can book their second vaccine at the same time. And so if you've got certain number of appointments a week, and if people are booking in through the NIBS, then that kind of sorts out, what happens in 6-8 weeks' time. You don't have to manage that as a practice. It's kind of managed already by the national booking system.
So there's a question here, just changing the subject slightly from bookings. Is it okay for unvaccinated staff to vaccinate, to administer the vaccine? Nikita, you want to talk to that one?
That's an ethical and employment issue. I think in general, as frontline providers, we would not support frontline providers in general being unvaccinated. So it wouldn't be something that any of us would support. We appreciate, though, that people have got a significant shortage of staff, and it's not always an easy one to solve. So I don't think there's a clear, simple answer to that, except that I think everybody would strongly support frontline staff being vaccinated to protect themselves, but also to protect the vulnerable patients. So if at all possible, get your staff vaccinated, even if they've got one dose, you know, you'd offer a reasonable amount of protection if you're getting underway while you're trying to get the second dose.
I think the only thing to, totally endorse what Nikki's saying, but it isn't a rule.
It's not a rule.
And there's nothing in the vaccine that's going to make them give from COVID or something like that either. So,
now, remember, there's pretty well hardly any contraindication at all. So there's not a reason not to be vaccinated. There is a timing issue that some people may have just got one and they're still waiting for their second. But I think as frontline healthcare professionals, we just got to support each other through this. We don't want to make it mandatory. We don't want it to be a rule. We want to work through it ethically.
Thanks. Kate, while we're answering some more questions, could you put up the slide of where to get information from? That somebody's asking if I think they probably want to take a picture of it.
Yep, sure. Is that showing?
And you'd need to share your screen again.
There we go.
That's lovely. Thank you. So we'll leave that one up on screen for people to have a look at for a minute. Is there a difference in foundation standards and accreditation practices with required standards? Anyone happy to take that one?
Yeah, I don't think so. I mean, ultimately, your local DHB has to be satisfied that you meet the standards required to deliver the vaccine. And what the DHBs have agreed is that foundation standards cover the vast majority of those standards. If you're Cornerstone accredited, obviously that's an additional layer of accreditation for your practice, but it doesn't specifically tick off more of the COVID vaccination standards. So that doesn't reduce the administrative burden anymore. I guess it's just if you've got foundation standards, then that covers the vast majority of it.
Okay, thank you.
Hopefully that answers that.
Right, so that's fine. Kate, I'm sure people will have had a chance to make notes of those now. So do we need a new computer dedicated to CIR, or can they incorporate it into their PMS systems on their computers? Is that one for you, Kate?
It's Google Chrome. So you get onto the CIR through Google Chrome. And what I would say is for administrators who are observing or welcoming the people into the practice, they just need to stay on the CIR and not switch between their PMS and CIR, because they do need to be observing the patients in the waiting room afterwards. So I think all practices are just having one dedicated administrator on Google Chrome, and that's how you access the CIR.
Thank you, that was a good question. There's a comment here from Helen saying that they used an event organizer to support their drive-throughs. So there's another possibility that could be helpful. Do we need 2 nurses to draw up and 1 to vaccinate? I can talk to that one. Certainly we do need 2 people drawing up, because it's really important that we get checking done. As you'll have seen in the media, there have been some issues with the draw up. It is the one part of the process that is very different from how vaccines are normally given in general practice. We've got really clear guidance around it, but it's very important that you have systems around that do allow for double checking. So there does need to be 2 appropriately trained people doing that checking. And obviously, even if you've got 1 person vaccinating, borrow a colleague for half an hour while you draw the vaccines up. They can be drawn up for up to 6 hours, although we do recommend that you try and set systems in place so that they use sooner than that, but you have got up to 6 hours. So you just need to organise your staff to make sure that you do have 2 people for checking. I don't know if there's anybody else wants to add to that.
The only thing that I'd add, Jane, is we really have seen community pharmacy step up in a massive way around COVID vaccinations and do some really huge numbers of vaccinations. And I have seen some examples of general practices collaborating with local pharmacies. And so in that type of situation, you could have somebody from the pharmacy, a pharmacist from the pharmacy come in, support you in the drawing up process and draw everything up for a period of time. And that's another way of reducing the general practices specific input into it. Obviously, you need to work out that arrangement with the pharmacy.
We're also allowing pharmacy technicians to be one of the 2 checkers as well. And we're putting some new training that should go live next week for pharmacy technicians. So that might be another option as well If you're doing collaboration with pharmacies, you might be able to borrow their technician for an hour or two or something. Right. If boosters become part of the process, do you think it would be easier to do in general practice? Who wants to talk to that one? Nikki?
I would just say that boosters will be coming, probably not this year, although boosters, or at least an extra dose, will be coming this year for highly immunocompromised at some stage. So I would have thought general practice particular is a logical place for that, because they are our client groups and they're our high risk, high needs client groups. Next year, this is me speculating, but I think it is highly likely that we would see a booster, probably initially for the elderly and probably frontline providers. So I think there's a role going forward for us in general practice. I appreciate it's hard to get up and going with these COVID vaccines, but there will be a role for us long-term going forward. You know, these are our customer base. So I would have thought this will be the long-term business for primary care and pharmacies. That would be my way of seeing it. So as we can get into the business of vaccination, I think it's probably worth this learning period to get into it. Remembering, of course, it may not be the Pfizer vaccine next year. We just don't know yet. And some of the other vaccines are certainly much easier on the cold chain and much less fragile. So, you know, from a pragmatic drawing up point of view, it'd be nice if it's non-Pfizer, but on the other hand, Pfizer is an excellent vaccine. So you gain and you lose on whichever vaccine you use.
And in terms of making it easier, lots of people have asked, why are we using a COVID immunisation register? What was wrong with the old National Immunisation Register? Just to cover that off quickly, that old system was very much at the end of its life, and a new national immunisation system was going to be established in 2022 anyway. So that the CIR has been built on the platform that was going to be introduced. And what it does mean is at the moment, it doesn't integrate well with our patient management systems. But the way that it's being designed is for the future is that it will seamlessly integrate with the patient management systems. And that's where all vaccinations will be kept. So in terms of making it easier, we will have to make it easier because that will be the single system that we're using.
I forgot one more roadblock. We hope to be moving on soon, that pretty soon we should be able to offer vaccines, certainly not with any spacing between a national schedule vaccine and the COVID vaccine, and eventually pretty soon concomitantly. So that's real business for us, with COVID moving more towards business as usual vaccination, which is what we do now.
The question here, when non-Pfizer vaccines come into New Zealand, will the process and CIR, etc., be the same?
I think, as Joe pointed out, the CIR will morph into the National Immunisation Solution, which was the previous national register. So things will change and alter, and I hope we'll get slimmed down and more efficient as we go along. But, you know, it'll just take a while for these things to change over, moving from essentially a pandemic vaccination delivery, moving over to a business as usual type delivery. So
I'm a new clinic and have not got foundation standard. Can I still become a vaccination site?
I think if you're, as long as you're already, are you vaccinating at all? If you've got your cold chain accreditation, etc., then yes, you will be able to become a vaccination site. Having the foundation standard, all that does is provide DHBs with a degree of reassurance around the quality standards within your practice. So there may be a couple of other things that you'll have to evidence in order for the DHB to take you on as a vaccinating practice. But if you evidence those, then absolutely fine.
So this one then follows along a similar line. We're a non-GP vaccination clinic and don't belong to a PHO. We've one vaccinator and one doctor and one administrator. We have a designated day session doing, if we had a designated day session doing 12 to 24 vaccinations at this level of staffing, do we have a show of being able to offer COVID vaccines through the Book My Vaccine system? And what support could we receive?
It would very much depend on the DHB where you are, but yeah, absolutely. I mean, it's just a case of starting that conversation. If you're interested in vaccinating, and the other thing, just to add to other comments people are making, if you want your enrolled population to get better access to the vaccine, then what we're seeing is those practices that are vaccinating have a higher proportion of their patients being vaccinated. So really that is a big call. If we can get just about every general practice vaccinating, that's going to be superb. So yeah, if you want to do it, but you think there may be some barriers because of your size, just have a conversation with your district health board. The message that we're giving to district health boards who have at the moment set up these big clinics is they're going to have to wind them down at some point. We're not going to have large scale clinics operating indefinitely within DHBs. So that's really going to have to shift the focus to primary care providers. So talk to them and see what they've got to offer. But just about all of our DHBs now are really aware of how important primary care is. And we saw that when we went into level 4 lockdown, those DHBs that had high levels of primary care engagement with the vaccine program, their vaccination numbers just soared. We saw that in Southern, we saw that in Canterbury. It's really superb.
So there's a question here which I'll answer. Can a healthcare assistant be the second checker for vaccine draw-up? And the simple answer to that is no. We won't. It has to be a registered nurse, pharmacist, authorised vaccinator, provisionally authorised vaccinator. But we are offering training for healthcare assistants and similar to become COVID vaccinators, working under the supervision of a qualified healthcare professional. So there's a lot of information on our website about that. It's getting late in the day, so I won't talk too much to it now. But they would be able to give the vaccine to somebody who had already been seen by a healthcare professional and screened as being suitable for having the vaccine, but they wouldn't be involved in the draw-up process. The only people other than healthcare professionals or with APCs that can check vaccines are the pharmacy technicians that I mentioned. But certainly there is a role there. We've got the support worker training that Kate mentioned as well, but there's a definite training pathway if you want to use your healthcare assistants to be involved in the vaccination programme. There's one here, get your crystal ball out, Nikki. Under 12s, when?
Yeah, that one is a really difficult one for two different reasons. Under 12s, as we know, children have more mild disease. So the argument is it worth vaccinating them as individuals? And it's not entirely clear if it is. That's the first issue, is it worth it for the individual? There are some kids who are at high risk, not necessarily all. The second question is it worth for us as a country vaccinating children to offer community protection? And that would be a strong reason for going with it. So it's quite a balanced argument at the moment. And then the third issue is ensuring that once the licensure comes through for these vaccines, that they're safe for under 12s. As we know, kids' immune systems are really vigorous. They're responding really well, these mRNA vaccines. We need to make sure they're safe. We're not seeing more myocarditis. So at the moment, jury's out on that one. I really wouldn't put my crystal ball either way. It's likely to be coming. I think America's talking about doing it first. So once again, I think it would be a huge advantage for us not to be first off the mark and watch and wait and see what a few other countries do first.
Right, I'm conscious of the time, and it may be that we don't get through to all of the questions. I'm just trying to pick out a couple more that, because it is already 12 minutes past 8, so it's great that people have been so enthusiastic. We've still got 180 people with us, which is amazing at this time of night. Future booster doses, is there any planning going into that?
Oh, in terms of the clinical advisory end, yes, there is. And of course, then that would then have to follow through to supplies. But there's certainly discussions underway. As I said earlier, it's very clear that significantly immunocompromised are going to need another dose soon. There is no rush for everybody else. The vaccine effectiveness is actually holding up very well till 6 months. It has dropped off a little bit with the Delta, but not hugely. So beware what we read in the public media. It's actually holding up okay. We will need a booster, but it will be next year, I would predict. Once again, this is Nikki Crystal Ball. Don't hold me to it, but it's not looking like we're going to rush into boosters straight away, except for the immunocompromised. The very elderly, of course, are going to need a booster earlier, because, you know, they don't, even with these great vaccines, get their immune memory doesn't last for quite so long. So they'll be first on the list, really. So look, that's, I think, what we'll be in the business for next year. So we're certainly not going to run out of vaccination business team. So, you know, I think it's worth us trying to get our general practices into this one.
And I think that also then answers this one. Being as it'll take 3 or 4 weeks to get up and running, is it worth it, since they're expecting everybody to be done by the end of the year? I think it's a very optimistic.
You know, do it as you can manage. We're all my own general practice is not doing it yet. It's a very small practice. It requires huge people and time commitment to get up and running. Do it as we can manage. We've got a lot of pressures on us in general practice at the moment. My only advice to all of us is this is business going forward. So at some stage, I would say, I suggest for all of us to think about how and when we can get involved in it, because it's not going away. And COVID, I doubt if we'll be doing COVID vaccinations yearly, although we may be for some really high risk groups, but we'll certainly be needing boosters on and off, not to mention all the other vaccines we're still underway with.
Okay, so how are we protecting our staff if other people are drawing up the vaccine? We will be doing the whole of the community, and we will see large numbers. I think because people have seen challenges before, well, one hiccup that was well publicised around the draw up, and this is why I'm saying it's really important that you have 2 people drawing up, checking and cross-checking, labelling the vaccines really clear, so that the vaccinator can clearly see what's in there, and it's, you know, initial to demonstrate who's done it. There's a responsibility and an accountability. The person that's prepared the vaccine, and then the nurse that's giving the vaccine takes the accountability for actually giving the vaccine. It is different from how we've always done vaccines in the past. It's a new process, but that's one of the reasons why there's so many rules and regulations around the draw up process and the actual training of the vaccinators as well. I don't know if anybody else wants to add to that. Right, we're getting there. Given the huge commitment and time it took to get this set up and running, why are there no, given the great commitment that it takes to get this up and running, why are there no financial incentives for that part of the process, especially if you've got somebody that's doing all this work for maybe a small number of vaccines? Maybe that's one Joe could.
Excellent. I get all the easy questions.
You do, Tony. That's why we needed you this evening.
Yeah, I think I just acknowledge that the price that we're paying for this vaccine per dose is significantly higher than what we pay for other vaccines. Probably best not to get into a debate as to whether that is a sufficient amount to justify giving vaccines, but that was where we were starting from. So that there is an acknowledgement of the increased effort to set yourselves up as a clinic is factored into the price that is being paid.
And finishing on, carrying on the same line, is there going to be a national pricing schedule for mobile vaccinations to people who are unable to attend clinics?
Yeah, so that's a conversation that's just happening at the moment with, so the DHBs have a group of their senior responsible officers who talk through this type of issue, and they're just having conversations now about whether there is going to be a national price set and what are going to be the types of parameters that are taken into account when setting that. So there should be more news on that over the next couple of weeks. I wasn't at the meeting this week where they were discussing it, but I've got one in my diary for next week, so I can't give an answer just now.
And so also on funding, how does the practice get funded for these vaccines? For giving the vaccines?
So there are 2 ways that you can be commissioned by your DHB. The first would just be as a standalone contract with your DHB, and some DHBs are doing that if they've got a provider that's meeting a particular need. Maybe that's for a priority population or a particularly remote area, but the majority of primary care providers and general practices are coming on a price per dose, which was the one that Kate included in her presentation. And if you're on a price per dose contract, you don't have to do any invoicing to your DHB, PHO, or to the ministry. All of the vaccinations that you give are collected in the CIR, and then the ministry generates an invoice and you're paid on a weekly basis dependent upon the vaccinations that you've done. So you'll want to do something within your own systems to account for the money that's coming into your account, but you don't have to send off any invoices to anybody else. It's a new system that was set up, so the first few weeks there were a few glitches that people worked very hard to then work their way through, but my understanding is it's now working pretty well and is a lot less labor intensive than old invoicing systems.
Right. Thank you. I'm conscious that we really are over time, so we do need to stop. Question whether there are any more providers needed in Auckland.
I think we always need more, but what we know is that people want to be vaccinated by their usual vaccine provider. And in a lot of cases, that would be the general practice or a community pharmacy. So once again, the more practices that we have available to do vaccination, I think the sooner we will reach a point where we've got as many people in the country that want to be vaccinated. So let's make it as easy as possible for people. And if one way of doing that is your practice vaccinating, then yes, please, we'll take more providers. And then finishing on the last one, which leads nicely from that, which is, will the model in future be more GP centric rather than the mass clinics and such like that we're seeing at the moment with the programme? Yeah, absolutely. I think general practice and other primary care providers definitely going to be the way forward. It's certainly all the conversations that I'm involved at the ministry. If we look into 2022, is primary care being the backbone of COVID vaccinations in the future. I think it really will need to become business as usual, or at least business of the future for general practices. Right, so that's the end of the questions. We have actually managed to address them, some of which we've answered by typing answers rather than taking up everybody's evening. So, Kate, do you want to finish with a karakia? And thank you all very much for joining us. It's been a really interesting discussion, and hopefully we've provided some useful information.
All right, thanks everybody. Okay, ka whakauria te tapu, kia wātia ai te ara, kia tūruki whakataha ai, kia tūruki whakataha ai. Hui e, tai ki e. Thank you.
Thank you.